find their time in the nurse's office because they can't go to class or they can't, go to gym class, and it's probably the first set of eyes on it. Of course, moms are certainly capable of seeing it, but again, many times in society, we're told women are supposed to deal with this chronic pain, it takes an average of 8 to 10 years for a woman to get diagnosed. That's because many of the practitioners out there don't know what to say, don't know what the symptoms are. Actually starting to collaborate with an investigator at Columbia University. Her name is Noemi El-Haddad, and she's come up with an app that's called Fendo. And Fendo is phenotype and endometriosis, and combined it makes the acronym Fendo. And basically it's a diary where women that suffer can upload the app. It's free, and to be part of the study, they first need to read and sign her consent. And the premise of what she's doing is she's asking women to put their day-to-day symptoms down and relate on what doesn't work. And the hope is not only to help the patient with what works and what doesn't work, but to come up with an algorithm of what symptoms women actually have as a teaching tool to teach the medical community, in particular gynecologists, as to what to look for when it comes into their office and complains. There's so many women that are told that what they have is either irritable bowel syndrome or, there's a pain that you just need to deal with, it's in your head. What I speak to, the frustration level that they have is palpable, and the curve needs to move forward. So in the study, what we ask women to do is to sign a consent, and basically the consent would be allowing us to recontact them, ask them for samples, namely a DNA sample, because this illness, chronic illness, we do see that there are genetic markers, and to be able to look at them and mark them and see what they are is really important. Looking at family members is important, and what we're focusing on right now is trying to understand what's happening at the cellular level. Asking women in the study to do is, once they've read the consent, filled out all of the questionnaires, and there's a lot of questionnaires. I'm not going to deny that we're asking a lot, and we're very grateful for it. We've adopted the World Endometriosis Research Foundation's gynecological questionnaire, which is a pretty extensive questionnaire. It uses branching logic. We do this all online. That I sent will have links for the consent, which is followed by a series of these questionnaires. And then finally, at the end of answering all the questions, there's a medical release form that's just for us to get pathology from any surgical procedures that the patient may have had. But as far as what we're looking at, we're currently focusing our attention on what's considered normal, and it is menstrual effluent. And there is a theory, and it's called Sampson's theory. Sampson was back in the 1900s, I believe it was 1920s. He researched endometriosis. He had patients that suffered, and his theory was that there is retrograde menstrual flow. That instead of the menstrual flow coming out through the vaginal canal like it normally does during your cycle, there is some through the fallopian tubes that spills into the pelvic area. Some of these cells implant. There is controversy over it. There are people that believe, well, if that's the case, why aren't we seeing in the vaginal canal where the cycle comes out naturally? And these are questions that we need to answer. But it is true that 90% of women do have retrograde flow. That kind of does explain why this is considered a chronic illness, because if you have retrograde flow, the chances are it's going to be more than one time. The other controversy that goes on with this illness is how to treat it. There are many gynecologists that believe just put some on birth control pills to regulate their hormonal release, or Lupron injections, which can be difficult because it's a 3-month injection of a hormone, that should mitigate the problem, but it doesn't work for many women. So what ends up happening is that they end up having surgery, which is ultimately the gold standard for diagnosis. So surgeons have 3 different ways of combating this. They do laparoscopic surgery, many use robotics, and there's small incisions into the abdominal area, and they either use ablation, which is scraping, they can use laser treatment, which is burning, or can use excision, which is where they remove the stem cell. And the analogy that I like to give when trying to describe to people what does this entail, it's just easy enough to take a look at your garden and see when dandelions grow. Nobody loves them except the Brits that like to make dandelion soup, but you want to get rid of those dandelions. So there are several ways you can do it. You can use a whacker, which is similar to ablation. You burn it, which I've never seen anybody do, but we're going to use this analogy, which would be laser. Or you can get down on your hands and knees and pull out each root. And hence, the results will be a better result if you do use that technique where you're pulling out the root. So the endometrial lesions that somehow find their way into the pelvic area, almost as though they're uteruses. So the woman may have some cramping during ovulation and her menstrual cycle. Women with endometriosis, these lesions are acting like mini uteruses, and hence the pain and all the symptoms become exponential. To where there are some women that are so debilitated that they can't get out of bed. As far as surgery, it does take about 8 to 10 years for a woman to get diagnosed, and a prudent doctor will look at how to treat, and if they decide that surgery is the best way, those are options. The issue with excision surgery, which is actually the kind of surgery that Dr. Sechkin uses, he's the founder of the Endometriosis Foundation of America. A problem with excision surgeons is that insurance tends not to pay for it, only because it takes longer. And insurance companies, look and see that risk of being under anesthesia for any length of time longer than you need to. So these are battles that happen at conferences, discussions that happen between surgeons. I've heard many of these conversations just going to some of the endometriosis conferences, having Dr. Gregerson bring in specialists in the field. Comparing endometriosis to other illnesses, it gets very little research. There's full of researchers around the world that are doing serious research on endometriosis, and Dr. Gregerson has pretty much met with many of them. This is not just an American problem. This is going on throughout the world. There's actually a large cluster of women in Iran. There's a researcher in Iran that talked about it. And of course, there are cultural reasons why women would not complain about their cycle or any disabilities that they may have. What we're doing in this study is we're looking at what's happening within the woman's cell by looking at these cells, and by getting a menstrual effluent, which is an easy process. I provide a kit that has a menstrual cup called a Diva cup. And, this is a cup that was manufactured in Canada. I think it was a Mother team that came with it. The company was kind enough to give these cups to us for the study because they were so excited to be part of it. And in the kit, I provide a collection cup with the Diva Cup, instructions, a way to get in touch with me. The subjects in research we call patient subjects. The subjects get my cell phone, so they can always text me or call me with any questions. And we ask for an overnight sample of day 1 or day 2 of their cycle. And for that is only by looking at these cells in a 5 to 7 day cycle. The cells from day 1 or day 2 are more viable, and we're able to grow them and culture them and run them through different assays, and we get really fabulous results. I can get to any woman in North America, have it come back in a kit that I'll send, which will have an ice block to freeze, a gel to refrigerate, and the box with the sample will mimic a refrigerator. So I will get the sample back. It'll start at 4 degrees centigrade, and I'll get it back between 6 to 8 degrees centigrade. So I tested it, and it works, and we have an MD-PH student works on menstrual effluence, and actually we're just submitting to the NIH, and we're very excited. There's a lot of excitement in the last couple of months, only because we're seeing differences. Women that have endometriosis have differences in stromal cell activity. Cells are kind of the support system. They are cells that work as support, kind of like collagen. And they are a little not as round as they would be in somebody that didn't have endometriosis, and they just don't perform the same way. So that's exciting. And not only that, but we're realizing that there's a decidualization problem. And what that is, decidualization is the formation in the uterus of a woman's body getting ready for implantation of the embryo. And we're seeing that women that have endometriosis, these aren't getting meaty and juicy and just aren't viable enough to accept the implantation. So hence that could explain some of the infertility that goes on with endometriosis. And that leads us to another group of women that we're looking at, and that is the group of women that suffer from infertility. About 40% of them will actually be told that they have endometriosis. That's what the statistics show. And we could be because of this decidualization problem. So we're working with Dr. Avner Hirschlag, who works within our health system. He's world-renowned in fertilization issues, and he is collaborating with us, and we're going to be having some of his patients maybe participate in the study, which is going to give us the breadth of information. As far as our controls, because in research you need that balancing act, you need to have a group of participants that don't have what you're looking at, so that you can make sense of what it is. And so we have a registry, which is something that I started working with Dr. Bergerson back in 2009, and that's called the GAP registry. It's a normal control registry, and it stands for genotype and phenotype. And what we're doing is we're asking women in that registry to participate in normal controls. What we're going to be doing is looking at particular markers. It's called the WIN4 haplotype. There's a particular genetic markers that we have genetic variants that do nothing. But for research, it makes it that more stimulating and interesting to be able to look at people. So that's the beauty of this normal control registry, is that people don't have to have illnesses, yet we can look at the samples that they provide and use them as a huge building block of gathering information to see what's normal and what's not. Excitement of what we're doing is far-reaching. I get to speak to women who are concerned about their daughters, and may have been told that their moms may have had difficulties but didn't tell them until they started suffering. So this is a socioeconomic problem that that all, and to hear the day goings on that occur to women with endometriosis, it's something that fuels the passion, I guess is the easiest way to say it. So what we're looking at when we look at some of these cells is we're looking at some mesenchymal activity, and the mesenchyme is kind of our house within the cellular structure, and noticing differences in some of the stromal cell activity, but also the mesenchymal activity. So there's a lot of evidence that looking at menstrual flow may end up being a diagnostic tool for us, because mom of a 13 or 14-year-old that can't get out of bed and can't go to gym wants to subject their daughter to surgical treatments to find out what is it that they have. Wouldn't it be great if we'd be able to have a test similar to a pap smear that might detect endometriosis? Another thing that happens is women are many times told that they have GI issues, whether it's irritable bowel issues or they've got gut problems, only to find out that they are sent to have a colonoscopy with negative results, or they're sent to possible surgery for appendicitis, and it ends up that there's nothing. And even having these surgeries, and find out you have no problem. I mean, it's just amazing that there are circumstances in the United States where women are being so misdiagnosed for so many years, only to finally find a practitioner whose light bulb goes on and finally mentions the word endometriosis. So I implore any woman that I get to speak to have a call to action. If you know a young woman or you know of any woman that's suffering and her symptoms may mimic difficulties with the cycle, possibly signs that may mimic irritable bowel, may have some issues with pain urination, hindering intercourse, just general pelvic malaise, endometriosis. I think we can't say it enough. I come upon many times where people don't have a clue. Everybody seems to think endometriosis is a small, minor issue until you finally meet that one woman who tells them their horror story. There are some rare cases where it can travel. I've spoken to a few women who have had it implants on the lung. That's rare. It's not a very common scenario, but it can happen. The majority of the time, the endometrial lesions stay within the pelvic area. Many times you'll find cysteries, but a good practitioner, a good gynecologist uses history and physical. The history would employ asking about aunts, siblings, asking about any infertility, any difficulties with unexplained hysterectomies, things of that nature. A physical would involve a rectal vaginal exam. Only by doing that can a doctor really get a sense of what's going on and palpate to see if there are any cysts that they can feel. That would be the history in a physical, or what many in the medical field call an H&P. After having that done, if there's suggestion of endometriosis, generally what happens next is there's a pelvic ultrasound. The suspicion is leading towards endometriosis. A good gynecologist will send that patient for an MRI. Those three things, the H&P, the pelvic ultrasound, and the MRI, generally gives a good hint as to whether or not this woman suffers from endometriosis. and either put on birth control pills or they are the decision of surgery takes place. Even if a woman has surgery, that doesn't mean it ends, only because this is chronic. And if truly Sampson's theory is correct and retrograde flow, it is going to repeat itself. There are some theories that believe that this could be a genital scenario. There are some scientists that believe that when young girls are born, sometimes you may see what may appear to be a small menstrual flow. There isn't any science to say that that's the beginning of endometriosis, but there are some scientists that do state that that could be. So there's a lot of questions. There's a lot of there's truly just a lot of research, which is why we really need to push forward. We need to talk as much as we can, and any woman that would like to be part of the endometriosis research OutSmarts Endometriosis study, we welcome them. The study is in North America, that includes Canada. I do have some in Hawaii. Getting samples from Hawaii can be a little difficult, but we use FedEx, and these things work out. I'm on the phone with men that call me. Many find us through social media, which is exactly how you guys found us. And we talk to practitioners within our health system. I'm constantly getting calls from within our health system from people that hear about us asking for referrals. And because we're not clinical, I do have all to come up with a prudent practitioner that's going to fit any one particular woman's son. So we do have some advisors. One of them is Dr. Harry Wright, who happened to be a surgeon who's retired now, but he is you'll usually find him at any of the endometriosis research conferences, and he knows all the players in surgical treatment of endometriosis as well as medical treatment. We rely on his input a lot, but again, finding the doctors that I can refer, I don't have that, and I'm sad to ever have to tell a woman I'm not a clinical setting as much as I'm a registered nurse. I work in research, and I can tell them about what were some of the women that are part of our study, but I don't have a referral, and that's something that I wish I did have. There are endometriosis centers throughout the United States. We've spoken to some of those practitioners. Some of them are wonderful. I hear great things from different women about them. We're hoping that in New York, that as well. Our health system is in the New York tri-state area. The 15 Institute is located in Long Island, which is outside. It's a suburb, a bedroom community of New York City. And we have some of our hospitals in the 5 boroughs, Brooklyn, Queens, Staten Island, and we have affiliates, and also Lenox Hill, of course, in Manhattan. There's some hope that maybe at Lenox Hill within the next couple of years we will have our own endometriosis study. So there's a lot of excitement, but it's not there yet, and unfortunately it's not soon enough. So say enough about the cause, the fact that I believe that women that suffer and their families need to write to their congressmen, need to call insurance companies, find out why they're paying for the types of surgery that they want to have. Why is it that they'll only pay for certain types, shorter surgeries? When excision may be the better outcome. And see if we can get some monies for research, because that's probably part of the reason why people don't do it. There are so many studies for so many other things that get funded beautifully, and yet for endometriosis, which again affects the socioeconomic nature of who we are as a people, gets so much attention. And it is my privilege to be part of this study. It's my privilege to work with the fabulous, brilliant minds that I do. And I'm in awe every day of what we learn. And the hope is that we will come up with a diagnostic tool soon. And our second hope is probably going to take us longer, but our second hope would be to come up with medication that would inhibit the growth of these cells that grow within. And Dr. Gregerson is an optimist, as I am, and hope that that's going to happen. Fortunately, research, the outcome of getting a medication from initial research can take easily 10 years. So it took us a while to get to that point, but we have high hopes. And as far as the study, I don't have much more to talk to you about. Just that some of the collaborators that we work with, like I said, is Dr. Hirschlag, who's a fertility specialist, Dr. Naomi El-Haddad, she's a PhD, and she is put together this Fendo app that we're actually going to be asking our ROSE subjects to participate in if they wish. I mean, there's certainly no push to do it, but I think the information is just going to make the breadth of knowledge that much wider, and have it so that we can come up with answers. So for the women that are out there in the world that have some infertility issues, the word endometriosis needs to be mentioned. For those that have unknown pelvic pain, the word endometriosis needs to be mentioned. And those young girls that are hanging out in their nurse's office with cramps needs to mention the word endometriosis, and trying to find them a good practitioner that can listen to them and do the correct physical history and physical, come up with a plan which to move forward and give them a fruitful life. As much as this is a chronic illness, we do feel as though we're going to come up with something and that women will be fine. And, we'll take these day to day. And I really don't have much more to say. So I'm open to having any questions and answer any questions that you might have. It is my privilege to talk on this topic. I'm not as a flavorful speaker as some are, but it would be my pleasure to be able to engage anybody in any questions or concerns or statements that they may have. Thank you, Megan.
Okay, I first of all didn't get a chance to introduce myself to everyone earlier. I'm Ian Elder. I'm the new program coordinator with the Riverside Medical Clinic Charitable Foundation. And now we're going to be opening this up to Q&A. At the top of your screen, you should all see a little button that says chat. If you're on the screen, it'll be along the green bar on the top. And so if you have any questions you can ask, you can send to all attendees or to the host, and then I'll go to me, and then I can go ahead and read those out for Margaret to answer. The question we have is to learn more about ROSE or to be a participant, anything like that. What are the best ways they can find out more or get in contact with you?
Okay, so there are a couple of ways. The first one is we have a website, and it's researchoutSmartsEndo.org. And it has our telephone number and all the ways in which they want to reach me. And there's a telephone number, and it's 56522-336, which is short for endo. So it's 56562-3636. They email me because that might be better. I'm happy. I don't want anybody to have to incur any expense in calling me. And the email is rose, just like the flower, ROSE, at northwell.edu. So that's rose at northwell.edu.
Okay, any type of compensation for being a participant, and also what a time frame for being a participant? How long does that last?
Okay, so there is really no compensation, only because our funding is minimal. We get small funding from the Endometriosis Foundation of America, and we get Diva Cups that are free. But basically, Dr. Gregerson covers the study, and there's quite a few people that work within the study. However, that being said, asking a woman to manipulate a menstrual cup to provide a sample is a very unusual, quirky scenario. And we want to express our thanks in every way we can. Probably the simplest way to do that is to provide a small stipend. So in the kit that I would provide, a woman that would like to provide a menstrual effluent, is what we call that sample, I will put a debit card in the kit, and once I get that sample back, I will upload on a debit card. It's called a Cling card. I'll upload $50 onto it. And if they give a repeat sample, every so often, Laura Warren, who's our MD PhD, that works on the samples, may ask for a repeat, only because she's trying out some different assay. If I ask you for a repeat, initially I'll ask you to hold on to that debit card. Again, once I'll send you a kit, and once you send me that second sample, I'll upload another $50. So, but for the DNA sample, because if you're close enough to me, I'll meet with you, I'll draw your blood. If you're not close enough, which I have to say most of the participants are not, I'll send what's called a buccal kit, which is a saliva kit. And for that, there's no stipend. For the buccal or the blood sample, there's no stipend. It's really helping us come up with answers, moving forward and helping. So that's about compensation. And what was the next part of the question? Oh, yes. The study is indefinite right now. To participate, once you provide us with the sample, we do different fashions. If there might be a scenario where somebody decides that they want to withdraw from the study, we hope that never happens, but obviously that's an option. If somebody wants to withdraw from the study and wants to destroy samples that they've given to us, they just need to write a letter and state that, and we'll do our best to destroy the study. If the sample's been utilized already, then obviously we're not going to be able to destroy whatever has been used. But the study is indefinite, and when and if Dr. Gregerson retires, which we hope he doesn't, there'll be some other young investigator that will most likely take it on. So have an end date as far as the study goes. And may always recontact. I mean, I speak to my subjects all the time. At some point, we'll have enough scientific information to send out a blast to everybody to let them know about. I mean, especially if we get this grant from NIH, but we'll let them know what we're seeing. It's just research is like a slow-moving turtle. Nothing happens too quickly. It takes a long time for us to come up with answers. As much as we have weekly meetings and multiple times in a day, Dr. Gregerson will walk down the hall and just talk to me about who he spoke to, what do I think, and I'll walk down to him when I hear something that I think he needs to hear. There's conversations going on. There's always discussions. There's, like I said, there's a lot of excitement about the subject. We've really become very passionate about it, unexpectedly, but we did. And for that question.
How many people do you currently have participating in the study?
So enrolled means that somebody has signed a consent and filled out all of the paperwork and provided a sample. We have 240 enrolled affected women. I've probably spoken to another, 5, and as they have copies of the consent, when and if they have the opportunity, they can always call me or complete the questionnaire and the consent and send it in. Lives are so busy and these women suffer so greatly. So as much as I speak to them, screen in and send them the information, not everybody follows through, which is a problem in research, is getting people to participate. So we're lucky and thrilled to have 200 and just about 240 affected women. And then we have about 75 controls right now.
Our ultimate goal number of participation?
So we have what's called IRB, that's the Institutional Review Board, and they regulate everything we do. Research has come under lots of scrutiny because of hazards that have happened in the past. When we put in our annual review, we put a goal for recruitment is for each year. It's an optimistic goal. So we put in a goal of 200 per year. We haven't met that, but this year I'm putting my annual review actually next week. This year we enrolled 100 women. So that's a decrease from last year. So we're getting towards a positive, we're getting positive. Having Dr. Hirschlog's infertility clinic going to be coming on board, we're hoping that we're going to get a lot of excitement from women that are trying to have babies and are trying to understand why they can't. So that is that the numbers will grow.
Next question that we have is, you spoke of your estimate of medication being about 10 years out, and also spoke of a diagnostic tool similar to a pap smear. Do you have any sort of estimation about how far out that might be created?
The medication 10 years is, do research and development in any scenario. If medication can be made 10 years after the initial onset of a study, that's considered very optimistic. As far as the test, because we're seeing differences in the menstrual effluent, the menstrual sample, we think that the test could
All right, having some technical issues with Margaret. Does anyone have any other questions to send in while we wait for her to get connected again? It looks like we lost Margaret, so I'll hear your question, Morgan, and any other questions anyone sends in between now, and put them up on our Facebook page for all of you to answer. One thing, you can look at Margaret's work and Rose's work on their webpage. And we'd just like to thank her for her optimism and her advocacy and research, and for coming to speak with us this evening. Thank you to all of you for joining, and we'll please for another wonderful speaker. Thank you.